This lecture is going to cover the management of acid, base, and oxidizer exposures and contamination. The objectives, we're going to recognize names of acids, bases, and oxidizers and describe the properties of those. List some routes of exposure for acids, bases, and oxidizers, and then recognize signs and symptoms of poisonings with acids, bases, and the oxidizers, and then briefly describe the treatments of poisoning that may occur through contamination or exposure of acids, bases, and oxidizers. So the top 5 chemicals resulting in injury from 1999 to 2008 are carbon monoxide, ammonia, chlorine, hydrochloric acid, and sulfuric acid. So carbon monoxide causes the greatest number of injuries. In the EMS world, fire world, we're pretty well versed in it, although we may tend to overlook the signs and symptoms of it instead choosing to view something a little bit more common. Ammonia release or exposure causes more evacuations than any other chemical, and it's the key or the name that household ammonia is called is ammonium hydroxide. And so hydrochloric acid is fairly common, particularly in transportation, as is sulfuric acid. So here's some common causes. So chlorine and hydrochloric acid accidents were most commonly attributed to human error. Sulfuric acids were most frequently determined to be due to equipment failure, and then sulfuric and hydrochloric acids have the highest frequency of release during transport. Sulfuric acid is also the most produced chemical in the country and is commonly used as a drying agent commercially. So in a release of chlorine, hydrochloric, and sulfuric acids, firefighters, EMTs, and response team members, and so response team members, you can also toss in personnel that might be responding, say, in an industrial setting, like an emergency squad or something like that. So our population, firefighters and EMTs, make up 3.5% of injuries, which may not seem like a very high percentage, but if you think about sort of the frequency with which we see this sort of thing, can be pretty high. And so we need to, in the industrial setting, we're sort of in we're at an advantage because typically we know what we're going into. But as a previous slide said, some of these are transported, particularly the chlorine and hydrochloric acids, and so you may run into those in highway or roadway accidents. Most events involving chlorine, hydrochloric, and sulfuric acids, however, will be at fixed facilities and industry, so that's going to be an advantage for us. So the routes of exposure, it's the ones we've heard forever and ever. So there's inhalation, ingestion, and skin and mucous membranes. So systemic toxicity does not typically present from just a mild exposure or from a general exposure. Frequently, it's a localized injury that leads to further or progressive injury. So one exception to that, particularly in that localized injury, is the exposure to hydrofluoric acid or HF. That is a little bit of exposure. It quickly moves its way to the bones and becomes extremely painful. And as it evolves or without treatment, the signs and symptoms of that go from it appears to it's nothing to where pain is out of proportion to what you actually see on physical exam. So there are acids and bases and oxidizers which do cause more issues, but we're not going to specifically address those in this lecture. One of the things you may want to look at, particularly with HF, is it's used frequently within the greater East Tennessee area. And so within industry, it's also in typical brake cleaners and that kind of stuff. And so having just a basic knowledge of the signs and symptoms of that can definitely be advantageous to your own practice. So routes of ventilation, there's skin and mucous membranes. Systemic toxicity doesn't typically present from the exposure. Again, it's that localized injury. It's going to get to be progressive injury. So the potential for inhalation is determined by the physical state of the chemical. So if it's a solid and it becomes powdery or dust, aerosol, or if it's fuming. However, less concentrated or more dilute acids usually don't have a vapor pressure that's going to allow for vaporization, so they stay as a solution. So kind of depending on what your emergency response guide says, or your NIOSH guide, or MSDS, that can give you a good idea about and a good idea about what the temperature is, the ambient temperature and relative humidity and pressure, can give you a good idea about whether or not someone actually had the exposure that they may think that they have had. Another route is the ingestion. Ingestion of low concentration occurs every day, right? Sodas, citrus juice, Monsters, Bangs, Reigns, all that good stuff. Local injury occurs to tissues along the path, and particularly the oropharynx and the esophagus. Now, the stomach acid has a pH of 2, so it's a pretty strong acid. And oxidizers, depending on the oxidizing power, can cause corrosion within that tissue. So oxidizers, hydrogen peroxide ingestion has resulted in erosion of the GI tract lining, kind of depending on the concentration of that, and generation of some oxygen or some gas under pressure, which could and has been reported to in a few cases to cause an air embolism. And then probably the more typical is that skin and mucous membrane. So injury from contact to acids, bases, and oxidizers, if affected by 3 influences. So it's going to be the concentration or the power of the chemical, the duration of exposure to the chemical, and then the integrity of skin and mucous membrane. So abrasions or more severe injury like a container rupture with the primary, secondary, and tertiary injuries from just the explosion itself or the rupture, and then you toss onto that the chemicals which may be released and then have contaminated and definitely exposed that patient. So with that, for instance, with an abrasion or some other injury to the skin, can lead to more rapidly evolving chemical burns, and it's going to be based on 2 factors. And so the mucous membranes, because of the function, they may more readily or rapidly evolve injuries and spread of exposure. So those 2 factors in particular are going to be the concentration and that duration of exposure. So acid, bases, and oxidizers. The acids, some pretty common ones are acetic acid, hydrochloric acid, nitric acid, and sulfuric acid. Okay. So acetic, hydrofluoric, and nitric, as well as sulfuric, acids against the skin may produce a coagulative necrosis. So coagulum is this thick and scab-like alteration to the skin, which you can see it's pointed out by the arrow there. Coagulation necrosis may decrease progression of a burn deeper into the skin because of that scab and that thick consistency, but that depends on the evolution of that coagulum. So the heat of hydration is the heat generated by the acid, and the heat of reaction is going to be that heat generated by reaction with biochemicals. Bases and oxidizers, so you got potassium hydroxide, it's a base, and then some oxidizers, sodium hypochlorite, and chlorine. So with bases, potassium hydroxide, you have this liquefaction necrosis. It's this chemical burn caused by a base due to denaturing these biochemicals. Liquefaction necrosis doesn't create like that coagulum like an acid would, so burning to underlying tissue may be deeper than an acid burn. These tend to produce a deeper, more severe burn than an acid, and these burns from a base kind of have this slippery feel to it, kind of the soap formation. It's saponification. So the take-home message is bases turn skin into soap, more or less, and frequently base exposure has more detrimental effects or can cause worse injury than acids. Okay, so what happens is that disassociation of that OH ion with the case of like sodium potassium hydroxide, right? So that soap formation is due to the splitting of some triglycerides into free fatty acids and glycerol. Okay. So the treatment, what's the treatment for this? So number one is always going to be to protect yourself, then your crew, and then the patients and the public. Like any sort of hazardous material, right? You want to remove the patient from the chemical and then the chemical from the patient. One of the things that has been said, let me actually, we'll get to that in just 1 second. So here's some treatment resources. When in doubt, all ambulances should have an emergency response guide. The 2020 edition is out. Also, if you're, particularly if you're dealing with patients that have had an ingestion or inhalation, poison control is at 1-800-222-1222. And then many localities also have a hospital, which they tend to call if they run into something like that. Additionally, fire departments, hazmat teams, if you're running to even auto parts stores, and particularly industrial settings, will have the MSDS sheets, which should give you a good idea about what the chemical is, what it does, and the ways to mitigate the effects of exposure or contamination. So treatment's pretty straightforward. So in a hot zone, so this is more of that fire department hazmat team piece. Pretty much the only treatment that should occur in that area is major hemorrhage control, right? So that's your tourniquets, things like that, and Advanced Hazmat Life Support's a big proponent of incorporating in TECC or TCCC management based on zones for any traumatic injuries that may occur during basically a hazardous materials exposure. So in the hot zone, we're going to major hemorrhage control if possible. Then we want to decontaminate patients. So for decontaminating patients, pH paper should be used. So for instance, if it was a localized exposure, maybe in a chemistry lab, somebody had an acid splash in their face, they did the whole emergency shower thing, you should get some pH paper, and you want to make sure that pH is getting as close to 7 as it can. And that includes any exposure to the eye. So you may need to put pH paper and apply it to the eye without, keeping in mind we don't want to cause any scratching or further irritation, to make sure that we're actually getting the pH down based on that exposure. Some treatments, particularly in chemical burns, specifically acid burns that cause any sort of blistering, some treatments recommend or suggest popping or lancing the blisters to try to expose any chemicals which may have been trapped between the blister and the underlying tissues. But that's one of those deals where you need to check your local protocols. So back to the slide. So we're going to decontaminate the patients. We're going to stop the burning process. So that whole dilution is a solution for pollution thing. So even with something like a lithium or something that may be somewhat hydroreactive or reactive to water, copious amounts of water frequently, if you don't have the ability to just do a real quick dry decon, can solve a lot of problems. So while we're stopping that burning process, we want to manage those A, B, C's, D's, and E's, right? And that can be done in a warm or a cold zone. Okay, so airway breathing, circulation, identify any disabilities, and expose that patient as much as possible. Treat life-threatening conditions first, using the most applicable protocol based on the patient's presentation. And so medics should consider pain management, because just like any other burn, this is a burn, and so we want to make sure that folks are being managed appropriately. So that concludes a really quick primer or overview of basic management to acids, bases, and oxidizers. And hopefully the take-home message is be safe, keep your crew safe, and then remove that patient from the chemical as quickly as possible, and then remove the chemical from the patient soon after that. References that were used for this presentation: the hazardous substance emergency event surveillance in 9 states, as was a CDC document that was put out, and then the Advanced Hazmat Life Support Provider Manual 4th edition was also used as a reference.